Hello everybody, welcome to episode 11 of Can Chats. My name is Eric Mojica, your host for the show. So today our guest is Matthew St. John. He is a doctor of physical therapy and also has a CSCS from the National Strength and Conditioning Association. And so it was really cool getting to know Matthew because we both went to Avila and he graduated from the Kinesiology program right when I got into it. But it was really cool getting to know him and just talking about how the program's evolved over the years. But nonetheless, we got into talking about physical therapy school and his whole process, his whole experience of getting into the program at Rockhurst. And so we just started talking about some of the clinical work that he does and his day-to-day stuff with working with patients and just how he likes to apply both principles out of strength and conditioning and physical therapy because they cross a lot of paths. And so Matthew also likes to work with athletes, and so we kind of got into how to prevent injuries, and really there's no answer to all that. It's just it always varies from person to person, and so it just comes with having really good evaluations and good assessments to kind of solve the puzzle of the human body to figure out, all right, what is this person dealing with? How did this injury happen? And how can we approach, not just physical therapy, but just fitness, exercise in general? How can we teach the human body to adapt and make some changes so that it can move better and feel better? With that, we talked a little bit about stress physiology and neuro physiology. And so if you're someone interested in getting into physical therapy, I hope you like this show and you get a lot out of it. On another note, if you're a personal trainer looking for some continuing education units, you should check out ACM 360 Pro. ACM 360 Pro was developed by Mike G, who was on episode 5 of KN Chats. And so in that episode, we talked about corrective exercise and how he developed the ACM program, how it has some modalities for ankle mobility, hip mobility, lower back pains, things like that. And so it's a really awesome tool that will help you just bring better results for your clients. And so if you're interested in getting some more information on how to do that, you should check out the website at acm360pro.com. And you can also find that link at our KN Chats website. And if you click on the links from the KN Chats website, you can get access to get up to $200 off on some of the programs that are there. But make sure you reach out to us either on Instagram, Facebook, or shoot us an email from our website at knchatspodcast.wordpress.com. So with all that said, let's begin the show. This episode of KN Chats begins right now. All right, everybody. Today our guest is Matthew St. John. He's a doctor of physical therapy and also has a CSCS. So welcome, Matthew.
Thank you. Pleasure to be here.
Awesome to have you, man. So just kind of want to start it off. You kind of telling your story, your whole background, where you went to school, and all your clinical work.
Okay, cool. So I graduated here, Avila University, 2013, with a degree in Kinesiology. From there, I started PT school at Rockhurst and graduated Rockhurst 2017 with my doctorate of physical therapy. From there, I got a job, Liberty Hospital Sports Medicine in the Northland, outpatient orthopedic clinics. It says sports, but we see a little bit of everything orthopedic-wise. And I've been there for almost 2 years.
Okay, awesome. Yeah. So what was probably the biggest challenges going through physical therapy school?
Physical therapy school is it's a grind. I mean, it's 3 years and it's very intensive, 3 semesters a year. So I would say just the grind of everything and just kind of how fast paced it is, just because you got so much content you're trying to squeeze in a short period of time. So just, I think the fast-paced nature of physical therapy school, along with just the amount of content you're getting, is probably one of the biggest challenges, while still trying to have a social life. And it was like right when the Royals were going to the World Series run, so trying to manage everything there is definitely trying to find that balance of getting the schoolwork done you need to do, but also trying to have a little fun as well. So.
And for those students who are watching this show and are interested in getting into physical therapy school, what's that process like as far as graduating with your bachelor's degree, and then what's the next step from there?
Yeah, so everybody asks me, okay, what degree do you need to get into physical therapy school? And you can literally have any degree, just as long as you hit all the prerequisites. I think we had people in my class who had communications degrees and just random things, but they had all the prereqs. So I think the biggest thing is just making sure you do well in your science courses. They look like, I think high GPA in your science and prereq courses are going to be very key. Getting a good GRE score as well, and then just being able to, not get burnt out on the application process, just because it is a long application, it's a long process. Be good at an interview, that kind of thing. But my biggest advice would be just if you're willing to put in the work, the rest will take care of itself, because they say some of the hardest things to do is just get into PT school, and then once you're in, then it's downhill from there. So,
yeah. Right on. So clinical work, how did you start off? Did you start working at hospitals, or how did that work?
So the way Rockhurst is set up, the first 2 years are based on building the foundation. So a lot of anatomy, a lot of biomechanics, exercise science, your differential diagnosis classes, medical conditions, neuro, all your base work. And then the last year is kind of centered around the clinics. So the way it's changed a little bit, but the way kind of my cohort we had a kind of short clinical, which I did in my hometown, and then we had 3 longer clinicals. And then you have to hit an outpatient, and then an inpatient, and then just kind of an out of town. So I got a good mix of a rural education, and then just some outpatient orthopedic. I did 9 weeks in an acute setting as well. So I got a little bit of everything in my orthopedic, and then kind of neuro clinical education. So, and then from there, I applied for a few jobs going out of school, and the Liberty Hospital was the best fit for me, kind of coming out of school, and it's been great since. So.
Okay, cool.
Yeah.
So, what kind of patients do you typically work with?
I work with a various amount of patient population. So I think my youngest patient right now is 9 years old. I think my oldest right now is 93. So just a wide range. Good range of pre-op, good range of post-op. Some people coming in with just some overuse injuries as well. So it's a good mixture of orthopedic post-op, orthopedic kind of pre-op, and then orthopedic just general. So I would say that probably 25 to 40% of my caseload is sports specific, but other than that, it's just general orthopedics. So.
Okay, cool. So what is a typical new session with a new person? How do you usually start that off, and then where does that progress to?
Yeah, so right now, just kind of in Missouri, we have to have a script from a physician. Hopefully that'll kind of change coming soon. I know there's a bill in the Senate right now to hopefully get us some direct access. But right now, just kind of you get a script from the doctor. It might say eval and treat hip pain, might say eval and treat shoulder impingement. You just get some general diagnosis. I kind of like it when it's more broad, just say hip pain, then I can kind of figure it out from there. So I start off with just kind of an interview, a subjective interview, kind of get a baseline of the history of what the patient's going through, just a quick kind of red flag check, yellow flag check, just to make sure there's nothing like serious going on that I might be able to tease out in my subjective interview. And then from there, dive deep into some movement patterns, some range of motion, some strength, and then if I need to do some special testing after that to figure out, okay, like is it rotator cuff, is it labrum, then I can kind of go from there as well. So.
Okay. And what are some of those general tests that you typically use?
General tests, it's like lower body. I watch, my patients don't know, but as soon as they come in the door, I'm watching them. So I'm watching how they walk, from the desk to the waiting room, to the kind of the table I take them to, or the room I take them to, just because if they don't know I'm watching them, then they're probably going to be in their more natural movement pattern, where if I'm like, okay, walk down to the wall and back to me, like they're going to change how they're moving. So I try to get a pre-basis on how they're moving, and then I might see, okay, how do they change their movement based off of that too. So I kind of look at that. If it's a lower extremity, I have somebody squat. If it's an upper extremity, I might have them squat with like in an overhead position. So I build everything around a functional movement, and then what's more functional than a squat in my eyes. So I try to build something, even if it's an upper extremity, I might build in like an overhead squat, or I might look at a push-up, or I might look at something functional. And then from there, go into range of motion, strength, and then my special testing. And then like if it's a back, then I'll look at reflexes, some more of those spine-specific things as well. So.
Okay. And so knowing the degree of schooling that you have, how much do you value something that's kind of like the functional movement screen, things like that?
I like the functional movement screen a lot. And I learned it here as a student, and I still use elements of that daily, whether it be the overhead squat, whether it be the shoulder tap, whether it be some lateral hop stuff. I use it quite a bit, and I think it's very valuable. You know, some people would argue it might be too cookie cutter, but for me, like, I think it's a good starting point. And I'm not basing my whole examination over it, but I think it's an important piece of my examination, using some of the components of the functional movement screen, and then the SFMA as well, because then that can kind of go a little bit more into treatment based as well. So
yeah, I agree with that. That's some stuff that we've been learning in the master's program here at Avila, just talking about the functional movement screen, and they have this functional capacity screen now. They have a couple other different ones that are a little bit more, I guess, athletic looking. And what we kind of just concluded to is that it's a tool, and so it just depends on how you use it. And if you know how to use it, how to apply to someone, then you can find what you're looking for.
No, I would agree with that 100%. You know, it's not the tool; it's just a tool, and it's important. You know, if everything's if you know all you have is a hammer, everything's like a nail. So it's important to have many tools in your toolbox, and I think that's a key piece to kind of practice and kind of how I use to assess. So.
Okay, and as far as being a physical therapist, how does the communication work with the doctor?
So I have pretty good relationships with with the majority of the doctors we work with, and most of the time it's just like take it and run. If anything weird pops up, you know, contact me. But you know, about every 10 visits, I'll try to do a progress note. If they go back before that, I try to do a progress note and send it to the doc before they go back. So I'm always keeping that in mind. Okay, how many times have I seen them? When do they go back to doc? Because I want to make sure they have the most updated information when they go back. So a lot of it's just, you know, faxing a note. Sometimes if something just strange is going on, or if I don't think they're progressing the way they should, or just something that's a yellow or red flag that's concerning me, I might get on the phone, talk to the doctor. Usually talk to a nurse, and then the nurse will kind of relay that, and then if it's serious, then they'll be like, okay, get them back, or talk to you directly. So a lot of that's just, you know, that trust that they have in me to do my job, and then just that know that if something's going on that's wonky, then that communication piece as well. So
okay. And what are those yellow and red flags? Like, what is it? Like, just strictly like range of motion things? Is it like something neurological, or maybe like they can't respond to something? Like, what do you look for?
Yeah, I think it just depends on the diagnosis. Like, you know, if we're looking at post-op, big risk would be like infection. So if I see any signs of infection, if I see any signs of clotting, that'd be a huge red flag. Maybe it's compliance. You know, maybe it's like, okay, they haven't showed up 4 times in a row. Like, I can't get a hold of them. Well, I need to let the doctor know, like, hey, like I'm trying all I can here. Like, patient's not compliant, kind of a thing. Or it might just be like, okay, like I know that they have back pain, but you know, this back pain is this, and this. Like, I think they should be looked at for something neurological or something systemic. So just using the differential diagnosis tools that we are educated on, just to make sure that the patient's getting the best health care possible, is kind of those yellow and red flags that we're looking for. So
okay, cool. And so I know you like working with athletes, so let's go into that. So what are the typical injuries, or what sports do you typically end up seeing? Is it really broad?
It's kind of cyclic, depending on, you know, the season we're in. So right now, seeing a lot of muscle strains, a lot of the track injury type things, you know, baseball players, a lot of shoulders, a lot of elbows. So we're seeing a lot of, it depends on the season. So right now we're seeing a lot of those early track, early baseball injuries, and then some of the basketball and wrestling injuries that could wait till the end of the season to get addressed. So so right now we're kind of in that. Towards the beginning of the summer, we'll see, you know, some more kind of the chronic baseball issues that I tough through the rest of the season, but now I need in. Might see some early like off-season conditioning injuries, and then from there in the fall, see some more football, cheerleading, soccer specific injuries as well. So I'm sure, you know, since in Missouri, female soccer seasons and in the spring, so we'll see probably in the summer, probably see an increase in ACL, some of the soccer type injuries as well. So it just depends on kind of the season more so than anything.
Okay. So a really big question that I get all the time as a personal trainer: why do injuries happen?
Got you. And I think I wish I knew the answer to that. You know, sometimes it's a fluke accident. You know, I landed wrong, I got pushed odd. You know, sometimes it's just like things you can't control. And then sometimes I think, you know, it might be a training, like maybe we've focused too hard on this and missed the issue on this, so it might be an imbalance issue. But as far as why they happen, it's just, I think our body can't keep up with the demands we put on it. whether that's a training fault, whether that's just we're pushing ourselves super hard, just something, there's a breakdown somewhere along the lines, and then when you get that breakdown, that's when an injury would happen.
And that's the hardest part for us, right? The puzzle is trying to fill in the gaps and figure out, okay, like this person was he or she not prepared
and
to do this task? Or
you have to be careful because you don't want to tell somebody like, yeah, I just don't think you were prepared. I think you were set up to fail. You don't want to put it like that either. So, I think it's one of those where it's like you know there's a breakdown somewhere. It's like, but like piecing that puzzle together, it's kind of fun though too. Just kind of figuring out, okay, like where are the imbalances at? Why are they having the symptom, and how can I change it? So.
And so, what are the biggest obstacles when you have a new patient who's an athlete and you might not have any, I don't want to say legitimate, but you don't have enough information from where they were before injury? Like, how do you go about trying to find how to get them back to playing time?
So, if I'm having a hard time figuring out where they were before, I know, okay, what deficits do they have right now? So then I always have a starting point. And even if they don't have any deficits, okay, like let's go back to the basics. Let's look at your basic foundational movements. So, we can always look at squat. We can always look at, if it's an overhead athlete, how does the scapula move? We have our foundational movements or foundational things that we can look at as a starting point, and then from there, as we go along, we'll get more and more information as we go along. And so, sometimes you might just start off very basic, but you tell them like, I know this seems very remedial and this seems very basic, but this is going to be the foundation for everything to get you back on the field. And usually if you put it like that, there'll be some fine with that. So.
Okay, cool. So lately I've been getting into a lot of neurology stuff, and actually this summer I'm going to be taking a Neuro Physiology class. Cool. And so it's kind of changed the way that I look at movement because, I was always kind of along the lines of, muscles move bones and everything is more postural based, muscle balance and stuff like that. But then the more that I kind of look into neurology, I realize that muscles move bones, but the brain function is what actually moves the muscles. And so just curious, like what do you know about neurology, and how much do you apply that to what you're, when you're testing?
I took a course recently on kind of pain neuroscience education. And some of the things that like we went over as far as like your body's alarm system and some of the foundations of like why do we have pain, started to connect some dots, like it doesn't even have to be a chronic pain patient to have this pain science kind of approach. So even if they're post-op, or even if there might be something, going on with kind of how we're perceiving pain even. So I wouldn't say I'm an expert on like neurology at all, but I am finding that there is a piece there, whether it's, like the stresses of like competing or getting a scholarship, or whether it's the stresses of just the brain being burnt out. I think there is definitely a neurological piece in kind of our practice, and I think we do need to tap into it, especially from a postural control, movement control kind of standpoint. I can make someone as strong as I can. They can test strong, but they might still be weak. So it's like, okay, there's something else going on here. So I think that it's a big piece that I wish I was getting better at, but I definitely think that there's definitely some room for development in that as well. So.
And the reason I say that is because I got to experience a little bit of that, because I herniated a disc in my lower back my senior year, and so I'm doing a lot better now, but I still struggle, with a lot of hip pain and lower back pain and stuff like that. And so I got to meet up with a physical therapist not too far from here, and he does a lot of neuroscience based kind of stuff, and so we did a lot of just movement screens, but he was also doing some manual testing onto my legs, seeing how well I can abduct, adduct, and stuff like that. And so it was really bizarre to me, but we were doing a lot of vestibular ocular drills and doing stuff to where, getting my eyes to focus on certain movements, and then just providing like a kind of palpation, just to provide a little stimulus to my body. And then I noticed, and I was very conscious of it, and my pain started to go away, and then I was able to move a lot better. And so it's just stuff that I'm just so interested in, and I'm just really curious on, how popular this is.
Yeah, one of my favorite things to do is like if someone's having a really hard time like moving their arm, or just like really fearful, is like you'll like kind of put a mirror and split them with a mirror, and it's like, let's say my left arm is the arm that I'm afraid to move. Well, I'll have them look in the mirror move their right arm, and then I'll have them move their left arm at the same time, and then before long you'll just see them start to raise their left arm a little bit higher because their brain sees, oh, like you can do this. So a lot of times, there is that neural piece in there. So.
And I think the part with that is that I think that our brain is just so designed into survival that it gets in a protective mode, and sometimes it blocks things from happening.
Exactly. And then sometimes just even more at a cellular level, we just keep getting constant stimulus, and the brain just, it's like, okay, well, I'm going to increase my threshold to a point where it's just like constant pain. So, yeah.
All right, cool. So more stuff on athletes. So what about the mental side of recovery? So how much coaching do you have to do with that? Because we wear multiple hats of what we do, right?
Yeah, and sometimes you have to be careful too. You don't want to get yourself in trouble. And it just depends a lot of okay, where are they coming from? Is, are parents pushing them super hard, or are they super motivated to play at the next level? Is it something that they're fearful of? A lot of times, even with ACLs, a lot of it is getting them to trust their leg again, or getting them hey, you can do this single leg hop. So some of it, there's a psychological standpoint of my leg's going to fail me again, or my arm's going to fail me again, trying to coach them up nope, you have the strength, you can do this, starting slow, baby steps, kind of build them up from there. And some of it's I guess if it's more of an external pressure, acknowledging that and then finding the way to kind of tiptoe and help them with those problems as well. So it's a little bit trickier when it's the external factors. It's a little bit easier to kind of deal with when it's just more of a fear of the leg failing you or your limb failing you. So,
and so how do those progressions kind of evolve from person to person? I mean, what do you look for? How do you determine, right, this person's ready for the next step?
Gotcha. So, a lot of times it's all objective based. So okay, do they have the strength on two legs to be able to kind of support themselves in one leg? So then I might put them on a shuttle and kind of do some single leg from there and be okay, do they have the control of single leg here to manage it more kind of in weight bearing or on the ground? So a lot of it's just kind of realizing okay, they've hit, in my mind, they've hit a milestone here, let's progress them a little bit further and not missing a step, because sometimes, it's they're doing better, they're feeling great. It's really tempting to kind of start something early before they might be ready, and that's the worst thing I can do. So in my mind, not skipping steps, even though if they're progressing well, and just kind of sticking to the foundations, that's going to build them up the best that I can. So.
And so what I want to ask you now is about your strength and conditioning certification. So how does that tie into physical therapy?
Yeah, and I think there is a relation there as far as strength and conditioning. In my case, I took my CSCS when I was in PT school with some of my classmates, and then from there we started helping the Rockhurst strength and athletic department and programming some strength and conditioning workouts for some of the sports teams there. And for me, that was a really good way to not only just get bodies and look at movement and understand movement, but at the same time understand, okay, this is how a 12-week strength cycle works, or okay, this is how we're going to build strength in 8 weeks. What does a cycle look like? And then, doing 20 reps isn't enough. Maybe I need to do, an overload, or kind of understanding basic strength and conditioning principles in a practical way was big, and kind of me developing how am I going to prescribe exercise to a patient, or just even communicating hey, your squat looks bad, or hey, your squat could be better and here's why, and kind of making those connections okay, they're shifting, what does that mean, and how do I correct it? So it was really good hands-on approach to kind of work on foundational movements like the squat, the deadlift, a press. So, and I still use, a lot of, I like using a barbell and weights and kind of how I practice today even. So a lot of what I do is strength and conditioning based. It just might be in a different scale, or it might be scaled down, or it might be just a little bit different. But as far as early on getting, practice at assessing movement and communicating movement, that was huge for me. And now I think it's paying off because I have those foundations of, okay, here's how you deadlift, here's how you squat, here's how you do these things properly, so I can feel confident that they're doing it in my clinic before they're going to do it before, back at weight class, for their sport, because I want to make sure that they look good doing it. And, if they don't look good doing it, well, I want to teach them okay, this is how we do it, because from the same time that's preventative, and that keeps them out of my clinic in the future. So.
And so I follow a lot of guys like Eric Cressey, Mike Reynolds, and so they all kind of share the same theme about things is, yes, like a good strength and conditioning coach understands the physical therapy world, a good physical therapist understands a good strength and conditioning background. And so
and we work in the clinic I work with, we have 2 strength and conditioning coaches that we do adult fitness and then athletic performance classes as well. So they're in the trenches, teaching movement patterns at an early age and loading them when it's appropriate or taking the load away when it's appropriate, and really just kind of building better athletes and by giving them a foundation of strength and conditioning. And then like once they work on the strength and conditioning, they go to practice works on sport specific stuff. So I think it's really important that kind of the work we're doing with the youth of the Northland, just kind of to build the foundation to make them better athletes and make them successful as well. So.
And so for young athletes, I'm talking about maybe pre-high school, in high school, what are the biggest recommendations that you have for them, just general athletes, as far as how to prepare, one, for performance, but also to prevent injury?
Yeah, I think, just building the foundation, making sure that, like, if you are squatting, make sure they have a really good air squat, making sure they have a really good squat to a target, make sure they have a really good, even if it's not a deadlift with a barbell, even like a foundational hip hinge or picking up like a light dumbbell, like making sure that those movement patterns are sound, because if your movement patterns are sound, when they're appropriate to be loaded more, when they're appropriate to kind of push a little bit more, those movement patterns aren't going to fail them. So I think just building your movement patterns and making sure, think about how you move, your setup positioning, your routine, kind of setting that in stone at an early age, that's going to make it more appropriate when they're able to load a little bit more in middle school, high school, making that a lot safer too. So.
And so you were an athlete here at Avila, right? And so how has, like, if you look back from today, looking all the way from when you started, how has everything changed in how you looked at fitness and getting in shape?
I was an offensive lineman, so I was 275, 260, 275 towards the end of my career. So a lot of it was like, I got to put on weight, I got to put on mass. So a lot of how I was training was just like eat everything in sight and then just lift heavy. So, and I wouldn't say that I put as much of a focus on a movement pattern because, I was 20, 21 years old, my body felt great, anything failed me. So I don't think it was until kind of PT school where I realized, like, yeah, I need to work on my foundational movements. I need to work on, not shooting my hips up when I deadlift, or I need to work on, keeping my knees out as I squat. So I don't think as much of a focus was put on movement patterns as it should have been. And that's to no one's fault. I think, the way that, things have progressed in the last 5 years or so, it's been based more on kind of, okay, we need to move better. And I think that's only going to increase from there. So.
And so did everything just change once you got into physical therapy school? Just how you viewed everything that you've done before and made you kind of rethink and
And I think some of the steps that the NCAA are making, making it mandatory to have like NSCA, like strength and conditioning coaches, or a certain, in your weight rooms and helping with, strength and conditioning in that standpoint. I think that's only going to kind of help kind of the way we look at strength and conditioning in the future as well. So. But yeah, like PT school happened, I'm like, okay, like this is probably why my knees hurt, or this is probably why my shoulder hurts when I do this, and then like kind of modifying that, and like, oh yeah, like my shoulder doesn't hurt when I do it this way. It definitely was a kind of an eye opener. So.
And so, how many baseball players do you typically work with?
So.
Is it often that you get to see those guys, or?
Yeah, we have my supervisor like specializes in baseball players, so he'll see the majority of the ball players, the throwers, but we do see a good chunk of throwers in there, and then every once in a while I get a couple as well. So it's a population I really enjoy working with, and that I think as a whole our clinic excels at really well because my supervisor is so good at treating those baseball players. So
what's your take on all arm injuries that happen in baseball? Like, what's your starting point? Where do you begin to look at that picture?
Gotcha. So, kind of the starting point is I want to know their throwing history. Like, how much have you been throwing lately? Is it a velocity issue? Is it pain? Like, what's going on? Number one, and then two, kind of, okay, I want to look at rotator cuff strength. I want to look at arm strength. I want to look at kind of just the shoulder girdle as a whole and determine, okay, is it a strength issue or is it something else going on? And then from there, kind of kind of diving more deep into the specific structure that might be hurting them, whether it's the elbow, whether it's the shoulder.
So how much do you attribute a pitcher's biomechanics into
and
injuries?
that's tricky because, you know, you look at the MLB and some guys have really good biomechanics and, you know, they struggle to hit the majors, and, you know, there's other guys whose biomechanics don't make sense, and they're throwing at an elite level and no pain and no injuries. So, you know, I think the biomechanics are important, but I don't think it tells the whole story either.
Right.
So.
Right. And so when it comes to shoulder injuries, so when I started playing, I was really into rotator cuff stuff, and all I knew was bands, going to internal, external rotation, going through all these band exercises. And then as my career went on, just starting to deal with more shoulder pains and things like that, I started to learn so much about the scapula. And for me, like, the scapula, it's such a tricky complex of that shoulder girdle, just because there's so many moving pieces in there. And so what can you tell us about just overall scapular movement, stability, mobility?
So any overhead athlete I get, I want to see how does their scapular move. And so, you know, I'm going to do, you know, overhead tests, see kind of where that scapular position ends up. Is it at mid-axillary line? Is it beyond mid-axillary line? Is it, you know, is it kind of below that? So how does it move? I might, you know, do some moves and see, okay, is there a restriction there? Look at some lat length, because that's going to affect it as well. And then from there, I might, you know, get them on their back and look at internal and external rotation. Okay, do they have the full motion that we're looking for, or are they lacking in a certain position? And then from there, dive deep into more of, you know, that rotator cuff muscle, just that complex. But I think, you know, that scapulohumeral, you know, movement is really important in kind of achieving full range of motion and kind of achieving, you know, what we're wanting to do with our arms as well. So.
What do you commonly see as far as those muscle imbalances?
Not
just baseball, but in general,
like which is an overhead athlete, or you know, a lot of times they might have really strong pecs and really strong, you know, front muscles, but then the posterior cuff, posterior, you know, subscapularis, supraspinatus might be a little, not necessarily weak because they're strong to begin with, but we might not be getting the most out of them as possible. A lot of times you'll see kind of scapula not getting to the point it should get to, and kind of overhead rotation as well. And then and a lot of times you might see an external rotation limitation as well, or you might see too much. I guess it just depends on the athlete, but you're going to see some sort of internal, external rotation kind of deficit as well. But a lot of times it's just more of, you know, my front muscles are probably a little bit stronger than my back muscles, and then from there maybe overactive lats, or we're relying too much on our bigger muscles, and our smaller stabilizers might not be kind of functioning the way we want them to function. So
okay, cool. So I have a really general question, and it's stuff that I really rely on my personal experience, how I felt with it, but heat or ice, when is the appropriate time to use one or the other?
So that's the $1 million question, and you know, it's such a funny even topic in the physical therapy world, because some people are very much in the, you know, heat before to increase blood flow, ice after to settle everything down. But then, you know, other people will be like, well, look at the research. One isn't indicated over the other. But I know from my personal experience that in the especially a post-op world, you know, ice after a session, or ice is going to help with that inflammation. It's going to help, you know, get our quads back faster, and, you know, knee injuries, or it's going to help, you know, just settle things down after we work it. So I think it just depends really on the person, but I kind of fall more into that heat before activity, ice after activity kind of standpoint. I don't really fall into the rabbit hole of chronic versus acute too much, but you know, as a general rule of thumb, I'll tell patients, like, you know, we want to make sure that we're warmed up, our tissues are feeling good before activity. So if you want to heat, you know, heat before an activity, and then if you want to kind of ice after, that would kind of help. But as a whole, like, I think it really depends on the case, and like some people just won't ice and some people won't heat. So just kind of finding that middle ground sometimes as well is important. So.
And that's how I always felt about things too, especially for baseball pitchers. I always just say, you know, do what feels really good.
Exactly.
If you're about to move, don't ice it.
Yeah.
You don't want to, like, I always give the analogy of, like, imagine you have a rubber band and then you just freeze that thing, and you start to pull on it, that thing will snap on you. And so what I learned was, what helped me a lot is I would always ice and then heat.
Yeah, a little contrast even.
And that would sometimes help me avoid general soreness, because I would get a lot of soreness in the forearm area. But I came across this video, and I can't remember who it was. I think it was some physical therapist that was talking about this, but He was talking about how the body has its own natural mechanism to reduce inflammation, and so how much do you buy into the fact that heat and ice can sometimes teach our body to rely so much on that ice and heat? What's your take on that?
You know, I think our bodies are really good at adapting to stresses we put on it. So I think there is probably something to, just like anything, like if it feels good, you know, our bodies are gonna be like, well, I need this to feel good. So I think there is probably a little something there as far as like becoming reliant on it or becoming like, I need this versus like, you know, just kind of letting things sort out how it may. But I haven't looked too much into that either. So it's hard for me to speak on that. So.
And what other tools do you guys use besides, you know, specific exercise? Do you guys use like stim therapy, any ultrasound stuff? Like, what's how do you look for like when this person might need these tools?
And you know, I think it just depends. It's a case by case, I think thing when it comes to if I'm going to use modality or if I might just use more of a manual approach or I might use more of a strength case or a strength approach. So no matter what, I would say, you know, if my sessions are 45 minutes, I'd say at minimum, you know, if I'm going to do a modality or if I'm going to do manual, regardless, they're still getting two units of therapeutic exercise or therapeutic activity, something just up and moving, because research will back up that your active treatments are going to be what gets the patient better, but you need those passive treatments every once in a while too to kind of, you know, work on range of motion or work on tissue restrictions. So, you know, I think my go-to is more of a manual therapy approach, whether it be a joint mob or whether it be, you know, maybe like an instrument assisted technique, or I know a lot of physical therapists will use dry needling as well, which discussion for a different day. You know, blood flow restriction, ice, heat, you know, ultrasound. It has, you know, has a purpose. I tend to, and what I see, probably don't use it as much. E-stim, you know, especially post-op, trying to get a quad going, I might use that, or might use more of what's called kind of a Russian stim. But I think it just depends on a case-by-case basis. But usually, you know, exercise, manual, and then just some of those post-op examples would be kind of what I use the most. So.
Okay, cool. So, what was the best part of being in physical therapy school?
I mean, I really enjoyed, you know, those connections you made. Like, even though it's a long, daunting process and it's a grind, you make really good friends along the process. And you know, sometimes it's just nice to think about like we thought we had it hard then, and then like, you know, compared to like the real world. But every once in a while it's like, man, I wish I could just go back, because you got to see your friends every day, you got to hang out with them outside of class. So I think, you know, just some of that just, you know, you're in it with 47, 48 other people, depending on your program, even more. Just some of that, like the connections you make, it's definitely, I don't know, I enjoyed that probably the most out of PT school. So.
Okay. Was school competitive, or was it really like unified? Like, what was your experience with that?
You know, I think it's really competitive to get in, and then I think once you're in, you kind of realize we're kind of all in this together, kind of thing. So, you know, it might be competitive, like in like the it's better than you kind of thing, or like that kind of thing. You know, you might get a little of that, but for the most part, it's like, okay, what do we need to do to get this knowledge down? And it becomes a real group effort into kind of getting the knowledge in and kind of taking it how we want. So,
were there any new study habits that you had to develop?
So I had to change my study habits a lot, because, you know, what I found worked for me in undergrad, you know, like that wasn't enough, or that, you know, that was good, you know, but I need to dive deeper. So I found that, like, you know, in undergrad I could, you know, put something off last minute, type it up the night before, get it in, where PT school, that didn't fly. So it's like, okay, like I need to make sure I have a good sleep routine, I need to make sure I have a good exercise routine, I need to make sure I take care of myself as well, and then the rest will kind of come. So I think from a time management standpoint, I got a lot better at managing my time. I definitely got more in depth and figured out, okay, how do I need to study, and kind of stuck with that. But definitely I studied a lot more, and I looked at sleep more and kind of some other things that, you know, you don't necessarily think about, you know, in undergrad as well. So.
Yeah, because when you're young, You got all the energy in the world, right?
Yeah, it's just like, like your professor's like, oh, don't put this off to the last minute. And we're like, well, I'm going to take that as a challenge now. Or in PT school, they tell you that, and you're just like, I better listen there. Yeah. So, you learn your lessons, and you adapt, and you get better at studying. And, especially for the boards, because the board exam was such a long process. Like, it was more of a marathon than anything. So 4 or 5 hour test, and like you have to build up to that. So like, I think, studying for the boards was probably like my, holy cow, I know how to study now kind of a thing. But, I wasn't used to putting in 2-3 hours a day, studying after being in the clinic all day. And I wasn't used to, maybe doing 6-7 hours on the weekend. So, I definitely think it was one of those processes where I was like, man, like I got out what I put in, but you got to put in a lot too. So.
And just overall in physical therapy, what's the dropout rate, and because I know it's really hard.
I don't know specific numbers as far as like PT school dropout rate. I know we started with 48, we graduated with 46, so I think that's really good rate. And I know there's a pretty high burnout rate in the first 5-10 years of practice, but I don't have those specific numbers. But there is a relatively high burnout rate, I think. But
do you think it's just because of just the amount of information you guys have to have? Or?
It's tough. I think, if someone were to, not necessarily drop out or kind of fall behind in PT school, just because of how fast paced it is, how much knowledge there is. But especially at Rockhurst, like the professors were so good in like making sure that like if you were having problems or if you were having trouble with something, like they would kind of take you up and be like, here, we'll help you, or we'll kind of like, what do we need to do to help you? They were really, approachable and like with their office hours and kind of being there outside of class as well. So I wouldn't know. So it's hard for me to, because Rockhurst was such a good, nurturing environment. It's hard for me to say for other programs, okay, like, is it the content? Is it that? Because, the experience I got was like, hey, like, just keep going. Like, we'll help you along the way if we need to. Like, you gotta, but yeah, I don't know much about the dropout rate.
Yeah, so. Okay, cool. So biggest influences in your career?
Actually, so this is kind of an interesting route, I guess, I took towards physical therapy. I have a twin brother who has cerebral palsy, so growing up we were in and out of the physical therapy a lot, and I would go along just because my parents needed to take me along too. So from an early age, I would say like Ben's early PTs were probably a big influence on like why I chose that, because I would see the progress he was making, and I'd see like the fun stuff they were doing, and I would want to do it too. And then from there, growing up in sports and like seeing that, like, okay, how can it, get me back on the field, or how is it changing athletes' lives? I think, from that standpoint, like it got me like really hungry to get into the profession. And then once I was in PT school, a lot of my professors became mentors as well after you graduate, because they want to make sure that you're succeeding. They want to check in on you. So then, you make PT friends along the way, and like you have like your support system of like people you can call if you're having trouble with a patient, or bounce ideas back off of too. So, I would say a lot of my colleagues too, that I met along the way in PT school and that I work with now, and that I met with and worked with in my clinical rotationships are definitely some influences and some mentors that I have now too. So. If you're a PT and you're looking for some good content to follow, though, I think Jeff Moore and kind of the Institute of Clinical Excellence, or ICE Physio, I think they're doing a phenomenal job. They're working on building mentorship and kind of a residency feel without kind of having that residency as well. So if you're looking, I think I utilize a lot of their content, a lot of their information. I think that's helping me kind of become a better physical therapist as well. So,
all right. Any other trainers? Physical therapists that you follow, maybe some blogs, some Instagram pages or anything?
I like the work that like Mitch Babcock and then Alan are doing with some of the clinical fitness athlete stuff. I like what like I said, what Jeff Moore is doing. There's a guy out in kind of Garden City, Kansas, I don't know his name's Brian Barker, but I think he's a great physical therapist as well. And then as far as like the prehab guys, I don't know if you've heard of them. I think they do a really good job. And then just off the top of my head, that's kind of what's coming to mind. But I'm sure if I sat down and looked at like content, like okay, like that's really good stuff. That's really good stuff. There's a lot of good stuff out there. It's just finding it. So
yeah, Aaron Horsey.
Yeah, the Squat University.
Yeah, that's one of my favorite ones.
Yeah, he does good work too.
Yeah,
so.
Awesome. So where can people find you? Emails, any social media pages?
My Instagram is all lowercase STJ_DPT. I'm trying to build that up right now, make it a little bit more educational, a little bit more informational. So kind of a process there. Twitter's STJ51. And then if you want to email me, Matthew, MATTHEW, STJ51@gmail.com. So.
Okay. Right on, Matthew. Well, thank you for coming.
Yeah, it's been fun. So
awesome. And if any of you guys want to give Matthew a little follow on Instagram or anything, make sure to reach out to him. I'm sure he'd be happy to help you with some physical therapy stuff.
Definitely. Any questions, just let me know.
All right. Well, thanks for coming, man.
Thanks for having me.
All right. And that concludes our interview with Matthew St. John. If you're a student interested in physical therapy school or have any questions about your own health, feel free to reach out to Matthew on Instagram, Twitter, or his email at matthewstj51@gmail.com. If you're a fan of the show, please make sure to subscribe to the podcast on all our media platforms. The show is available on YouTube, SoundCloud, and iTunes on the Apple Podcast app. Follow us on Facebook and Instagram, as well as our website at knchatspodcast.wordpress.com. I want to give a huge shout out to all our viewers and listeners. Thank you for following the show, and please make sure to share the podcast with your friends and family. Also, if there are any specific topics or questions you'd like for us to cover on the show, please let us know in the comments on any of our KN Chats pages. Stay tuned for more episodes because we have more coming your way. This is Eric Mojica signing off. Until next time, this is KN Chats.